Okay, do we have the leadership from each of the organizations here? From Armor, CCS, and Verizon. I know Verizon's here. They're just here. There they are, and I guess everybody is present. Okay, cool. We'll start off with Ms. Kuzak. You have your light on, ma'am? Questions? The floor is yours.
Thank you, Mr. Chair. Thank you for coming here today and wanting to continue to do business or wanting to start doing business with Volusia County. I have some questions, and I guess maybe I'll ask the same provider each of the questions.
You have the floor. It's your call, ma'am.
I want to talk about from a legal standpoint, I'd like to know about your history of litigations and incidents in the facilities in which you represent. And I guess we can go in any order that you want. My call then would be Armor.
Just to confirm, is it okay if an individual who's very specific to that answers the question for us? I mean, our COO?
Yes, for me, that was who I would want to answer.
We've been in business 10 years. We have averaged about 20 lawsuits a year. So we have just about 200 lawsuits in our 10-year history. As I mentioned earlier during the presentation, well, first let me back up. 80% of those are pro se, which means they don't have an attorney to represent them. And 95% are resolved, either dismissed as summary judgment or go away for some other reason. We have about 5% that end up in a settlement. And as I said earlier, the two types of settlements, there's ones where we realize we made a mistake and we work quickly.
How many have you had within the last 5 years that you realized you made a mistake?
Well, we have 30 total, so I would, in the last 5 years, I'd say maybe 18 to 20. Company-wide, yeah, it's company-wide.
Company-wide.
It's across, we have 44,000 inmates we take care of. We're much smaller than the other folks who are here, so our numbers will be big.
Aye.
Is that okay?
That's good, that's good.
Any other questions on those? We've had no judgments.
No judgment.
No justice, no matter.
Then, do you want me to ask all the questions I have of Armor first? Because these same questions I will probably have in some form.
Well, it is totally, you have the floor, ma'am, and you may ask.
So we have no procedures to how?
No procedures, because believe it or not, the questions that you may ask, Ms. Denny's may ask, or I may be asking, or somebody else may be asking, so actually, you are asking some of the questions I was going to ask, and so I'm writing down notes.
Okay.
All right, so
My
please,
next
you have the floor.
question would be about the electronic records, medical records.
Yes, ma'am.
Tell me about your system.
We use two different, we looked at designing our own, and then we thought, let's not do that. Our expertise is delivery of healthcare, and we thought if we lose a contract, then we could say to the client, well, we're going to take our EMR away. So what we did is we went out and negotiated. We looked at all the EMRs on the market, and we decided on which one we thought was best for the business that we did, and we went out to those guys and we negotiated a contract with the A, most favorite nation clause, so nobody has a lower price than us, and B, we made them agree, or we got them to agree that if we lost a contract for any reason, that they would agree to keep their system in there at the same rate that we negotiated. So the client, there'd be no stoppage in service. You could continue on as long as you wanted with that EMR system. So we use two different systems. We use one called Core EMR, which is built from the ground up just for corrections, and we use CorrectTech, which also has a doctor's office component, but it has a corrections component as well. We use Core EMR most. CorrectTech is one that we only have in a handful of sites. So that's Core EMR is the one we use. We believe in EMR. We have customized each of those to meet the standards that we have in place. So somebody may have that system in another jail, but if it's not Armory, it's going to be a different product than what we have. We have a lot of triggers and things that we have built into that is not in the regular system.
So then, if you have a client, an inmate who is coming to you, could you, and have had been in a system someplace else, does your system provide transfer of those records?
It can. No system can unless you build that interface, and this system can build the interface with any system. We haven't had any issues with that thus far.
I want to talk to you about your mental health piece.
Okay. Can I get our mental behavior health, because that's something I can't.
Yes, ma'am.
Thank you. I want to talk to you a little about the bridge program for psychotropic drugs. Do you have something in place to how you deal with psychotropic drugs?
Currently, we have the emphasis on the client and the community needs. Right now, policy-wide, anyone who's discharged from the facility, we give them a 7-day supply or a prescription for medication. Working with SMA, we looked at their psychotropic, their pharmacy that they had, and ways to maximize that specifically here for Volusia County. When we emphasize the continuity of care, since they are the community providers coming in, we pretty much would know what medication is the community standard. So working with their pharmacy and perhaps some cost savings. When you said the cost of psychotropics for the aggregated cap, that would probably be reduced with utilizing their pharmacy.
Ms. Kutek, one moment. For everybody in the audience, if you're going to speak, you have to identify yourself and your position. We are online, and not everybody knows who you are. Matter of fact, I don't know who any of you are. So you'll have to identify yourself and your position, and then answer the question. Okay, I'm sorry, Ms. Kuzak, you still have the floor.
Thank you. When would the decision be, are there guidelines that you use as to when you would make the decision to call Stu and Mothman and to proceed with the mental health piece? Is that at the beginning of entry, after an evaluation? Talk to me about how would you work a program through?
So I'll just identify myself for the record. My name is Maria Brooks. I'm the Corporate Clinical Coordinator for Behavioral Health. Actually, the catching at-risk individuals starts at intake. So we have a pretty comprehensive screening that identifies at-risk individuals and symptomatic individuals at booking. Those are typically trained by our medical staff. And it's pretty structured, and it's based on 30 years experience as well as community trends and needs that we see at all our various jails. Once that's identified, there are certain risk factors. And if there's any question or doubt, they can always call up a mental health provider. We have on-call services, as well as a pretty structured guideline. Any form of safety, we'll place them on a safety precaution right away. Individuals with detox, so there could be the co-diagnosis with mental health and detox. We always want to work collaboratively, medical and mental health, but we always want to treat the detox symptoms first with that relationship. So right at the door, we're addressing mental health and substance use needs.
If a person comes in and is taking medication of some kind, tell me, and you're not sure if they are there, if that medication has been prescribed, how would you handle that? How do you work with that?
Well, if you don't see my passion, I'm very passionate about patient care and the delivery of that patient care. We do go some self-report, but we also have to identify the active symptom impairment. And sometimes people may be receiving treatment in the community. That's not the best. We always try to verify active medication. So we are at booking, getting release of information and contacting primarily pharmacies, because not everyone remembers their doctor's name. So we'll get the pharmacy. And again, if there's an active prescription, we'll call and get verification to start that medication. If the individual has symptoms of detox or report substance use, we always want to address the medical components first to make sure they're safe. If they're saying they're taking psychotropic medications while using intravenous drugs, we want to make sure the patient is safe before we start them on the psychotropic medications through the medical detox.
And your medical detox with, is there a period when they are on no medications?
Yes, there is. They're based on their symptom impairment, and Angela's can speak more to the detox per se, but based on their level of symptom impairment, the medication intervention is given, they're followed up, and throughout their detox, they're working with both mental health as well as the medical team. I don't know if you want to know more specifics about the detox.
I just want to know if a patient is there and you're not certain of the medications that they are on, or even if there is a prescription, so you don't have a prescription, but they're taking something.
There's
Do
a
you take
variety,
them off of all drugs?
variety of ways that we address it. Angela Gehring, Senior Vice President of Clinical Operations for ARMA. It's a variety of ways. It depends on the patient. If the patient can tell us what medication they're on and they know their dose, which is really the exception versus the rule, we pick up the phone and call the provider and get the order to continue that medication. The patient says, I'm on a medication, but I can't really remember the exact name of the dose. As Dr. Brooks said, we'll do our best to notify the pharmacy, get that information. But the most important thing is that we assess the patient here and now, before me. Are they symptomatic? Even if you can't remember what it is, if they're symptomatic, I have a good history coming, we're still going to pick up the phone, call the provider, and let them make the decision. Am I going to order something here today? Is it somebody that I want to see tomorrow? Or can it wait 3 or 4 days? For example, if it's a psychotropic and the patient says, I haven't had it in a few weeks, that may be something that we put off for 3 or 4 days. If it's a blood pressure medication, we're going to pick up the phone, get an order, and go ahead and initiate the patient, even if they can't remember the name of the medicine. So there's a variety of ways that we're going to address that based on that patient's presentation to us in the here and now.
And if I could just add, Ken Pullen, the Chief Operating Officer, if you're interested, there is a service that we can utilize where you can electronically identify what prescriptions that an individual is on, and it's virtually real, well, not real time, but it's very quick. So you can use that as well if that's something that you're interested in.
Angela
Thank you.
Gehring again, and the other piece that we do is if, because of recidivism or return to the jail, we do have a certain complement of patients that are there frequently. Obviously, the first thing we do is grab that old record and see what the plan of care was in their previous admission. The patient may not remember, but we have that record, and with your adding electronic health record, that's certainly going to speed things along.
Thank you. Verizon, I'd like to ask a question, is how are you dealing today with your bridge program for patients who come in with mental illness or who's on something? Do you take them off, or how do you process that system?
It's very similar to what you just heard. Person comes in, they're on medications. We have the benefit of having SMA working with us. And they pretty much know almost everybody in the community. So, however, it is true, most people come in and they might know that what meds they're on, but they don't know what milligrams, say, that they're taking. And we did price and suggest that we get Inmate in here because within 2 minutes, you can actually have any medication that they've gotten between here and somewhere in California, and you can make it within the last 30 days or 1 year, and it really is within 2 minutes. You can verify them. And then it would be up to the intake nurse, who's ever doing your intakes, to do a very thorough screening, look at the presentation of your patient, and then get on the phone to the doctor and talk to the doctor about it, and it goes from there. But we do have medications at the site that we can provide immediately.
Okay. Tell me about your agency nurses. Do you have any?
I can actually say very proudly that we have not used an agency nurse in the jails in the Southeast region since 2007. I need people working in my facilities that are passionate about what they do, and I just haven't really found that agency engagement when they come to the site to actually, they're just not engaged. They're in there one day, out the next. So I work very hard to keep agency out of facilities, and not really. 2007.
I'd like to ask that same question to the other two providers. Have you used agency nurses, and how often, and what's your
William Kissel,
philosophy?
Vice President for Regional Operations. We do not use agency
Regional operations.
for Correct Care Solutions.
Thank you.
Excuse me. We do not use agency nurses. Our employees are full-time or part-time CCS employees.
And the same thing for CCS?
We are.
Armor is the one that is.
I want to say, out of Bruce Teal with Armor CEO, out of our 28 accounts, there's 2 contracts where we do use agency nurses. They declined. One of them is, last time I checked, was a total of about 8 shifts. Now, actually now, just one site. So, similar to our, everybody else here, we prefer not to use them, but when it comes to the part of just literally on a day-to-day basis to have somebody in there. They go through the same training, the same orientation before they need to use. But certainly it's our goal not to use it, but I can't sit here and say that we never use agency nurses. So, there's on one account site I know we have, so, okay.
Would you say that it's pretty common that you use agency nurses?
Absolutely not. I think that right now, the 28, and I'm looking at our finance gentlemen, I want to say there's now just 1. So absolutely not. I believe 2 years ago, the most recent statistic I had, I believe it was less than 2% of the overall FTEs, and that number is now down. So, no ma'am, absolutely not. Very rare.
One of the providers, I think it might have been Armor, that said that they would be having someone in-house to do the ophthalmology type program. Talk to me about that.
Ken Fulham from our COO. We do use in-house optometry, if that's something you're interested in. Absolutely. And let me just back up, if I could, just to clarify. Our proposal also would have SMA as our subcontractor for that, so we would have
Yes,
those
I
folks.
know.
Okay. And
All
on
three
your
of you
bridge,
have-
we don't call it bridge, which, and it's just a different title, but we do have the, in fact, we won program of the year for our discharge plan, to make sure that when somebody's released back into the community, they have their medication, and hopefully by then they have an appointment so that they can follow up, so that they can stay on their medication and we drive down the recidivism. We have some pretty good statistics.
And finally, I want to ask one about the specialty program as it relates to OBGYN. Who wants to take that?
Kim Christie, Transition Coordinator with Correct Care Solutions, and if I could just go back to your question that you asked about the optometry. We did indicate that we've established actually a nationwide agreement with a company called Institutional Eye Care, and they included we included in our proposal a letter of intent from them to establish an on-site optometry clinic at the facility.
Well then, talk to me about the last,
Specialty services.
the specialty
for
services,
OBGYN.
yes. I want to know about dialysis, and if you would be able to, in your company, provide in-house dialysis, or would they all be transferred out for dialysis?
We very frequently provide in-house dialysis services. We actually have a national contract with a company called Chardonnay. We understand that there is a current provider in there, although it would appear as though the volume of service at the institution is pretty low. But I believe the current provider is Fresenius. We have reached out to them about their interest in continuing to provide services at the facilities. And we've actually had some experience in other counties where we had dialysis chairs, but they weren't utilized to their fullest extent, where they actually had an agreement with other counties to bring inmates in to have the dialysis services, which ultimately lowered the cost for the county that had the chairs, that really weren't being utilized to their fullest potential.
Any of the other 2 providers would have in-house dialysis? Talk about the dialysis program.
Angela Gehring, Armor Correctional. Thank you, Commissioner Cusack, for asking both about dialysis and the OBGYN services. OBGYN services, absolutely, we bring an obstetrician gynecologist in to see the pregnant women and any gynecological problems that we might come upon. Typically, however, They may or that may or may not be their physician when they deliver. We'll work with whatever hospital or place that we're going to send that patient to for delivery. In the event that they're discharged prior to their delivery, there will be an appointment and that safety net set up for them in the community so that ultimately that patient can have a healthy baby. Dialysis, yes, ma'am, we do bring it in, do it on site, and we also would provide a nephrologist to set up that plan of care and continue with that patient.
Thank you.
In like the BPO Horizon. Dialysis, we brought that program to the jail, I think it was 3-4 years ago, and we do in-house dialysis at the facility. It's a lot safer for the community if you can do it that way. And the OBGYN, we have a nurse practitioner at the facility. She does about 8 hours a week of OB, care for our pregnant inmates, pregnant females, which sounds strange. And we also have a contract with Dr. Carbonet over at Halifax Hospital. And again, she works with our drug-addicted pregnant women who are even at more risk than, I mean, all of our patients are high risk when they're pregnant, but even more high risk. And so they are taken care of at on-site, and then when they're going ready to deliver, they're over to Halifax Hospital. And we do alert her that we do have one, whether it's in her care or not. She'll take a look. And with Dr. Mosley, who's also watching over everybody in Halifax Hospital at the same time, so we have good care.
Thank you, Mr. Chair.
Good morning, Dr. Gonzalez, Regional Medical Director of Horizon. Just want to just mention thank you very much what you said. Every time we have more women coming pregnant with high risk, and every time we more sick or using any drugs, we follow these patients from the time they're coming in. So we have the nurse, the OP nurse that is there 80 hours during the week. And she also follows those patients. So also we are on call all the time. So now the providers are there. They can call the provider anytime. The patients also have the ultrasound as soon as they get there to be sure the baby is all right and have no any other issues with the baby. Just want to make sure that you mentioned that.
Thank you. I yield the floor, Mr. Chair.
Okay.
Thank you so much. Let me just say, I appreciate all of you answering my questions, and this is a big deal for all of us, the community as well as the providers, and thank you so much for putting yourself out there to want to do business for the citizens, the folk that come to Volusia County. Thank you, Mr. Chair.
And Ms. Stennies, you have the floor.
Thank you. Do we have those numbers on the actual contract value for 11, 12, and 13?
These are our expenses. One of the associated ADP. That's just
Average daily ADP is average daily population. And so, yes, the average daily population. And the total is, the total that we paid in contract, okay, that's our final cost. All right. Well, that kind of starts, I just passed out something to council. If, Marcy, if you could put that in an overhead projector, since it's all public record now, everybody has presented. This is a document that we were given in a meeting with staff. And what I looked at in, especially, well, our current provider, Horizon, what I looked at the base ADP, the average daily population, what the suggestions were, I was intrigued that you started out with 1475 when indeed the baseline is well over 1500. And I'm not sure, staff could maybe answer this. When we did these projections, did we give the ADP, or how was this presented when it went out for RFP?
They were given data that gave our historical ADP
they were given the ability to bid differently from what they saw.
Okay.
So they have that ability to make some sort of a reasonable estimate in the direction.
Okay, thank you. And here, I'm struggling with a couple concepts here before I go past this. We have the asterisk in the middle, the less specialty cost sharing included in the base rate, the assumed specialty cost. And I'm looking at the final, in 2013, our actual contract with Horizon, we ended up and paid 7.6. But yet the annual base cost in presenting in 2015 is only estimated at 6.8. And then you've got the cost sharing. I have to tell you, this is extremely confusing based on existing data, based on where we are currently. Looking at this and how you could forecast reasonably what the cost would be. And you're going to have to convince me why the specialty cost sharing is subtracted from the actual value. Obviously, two of the three vendors chose not to. I mean, the price is the price is the price. And why, in especially a for-profit corporation, which all three are, correct? All three are for-profit? That's a fair statement? In a for-profit situation, why, because 1.2 million, and we look at 2015 with Horizon, you take 1.2 million out of 6.8, that's what percentage, that 15, 20% right off the top you're willing to say we're just going to absorb? What am I missing? Somebody has to explain this to me, because I have tried to wrap my arms around this many, many times, and just when I think I understand it, I look at the numbers again and say, in the business world, I don't get it.
Mr. Robinson will.
If you look at, I'm looking at Horizon because they're our current provider, and if you look at 2015, you see the red, the negative 1.248?
I assumed, and hopefully they can correct me if I'm wrong, I think the assumption is from a government standpoint, it puts skin in the game, so they have their incentive is to save us money, because if they don't, they lose money. I mean, I think from a business standpoint, a government standpoint, in case I'm wrong, that's why you do that, right?
Yes.
Because if you don't find the savings, you lose money.
Exactly.
They find it, we both win. I think that's why you do something like that.
That's it.
Which is also why I would have concern, I mean, I would assume we would want the other two to do it as well as part of it.
Well, I'd really like to hear it from them, because we've also got the base assumed specialty cost, and I understand that that's a self-insured concept, so it's not a savings cost, it's either we're being overbilled to begin with. This is business, and this is business.
No,
Big
Ms.
business.
Denny, Mr. Robinson prepared that chart, and I think he's best qualified to explain.
Please.
This is John Robinson, benefits consultant for the county. What we were asked to do is trying to do an apples-to-apples comparison on the proposals that you received. In doing that apples-to-apples comparison, what we did is we looked at your current arrangement with Horizon, and your current arrangement with Horizon has part of the specialty risk portion as a part of their actual base price. The proposals that you received from Armor and CCS included an aggregate amount or a specialty amount, but it was not included in the actual base price. So what we tried to do is separate those out in giving you the actual costs themselves. In looking at the current arrangement with Horizon, the current contract for 2014 is based on 1,425 inmates, average population for the month. Their current rate is $385.70. I think it was a base of $6.6 million for the base price. In that base price is a part of the specialty cost. A part of the specialty cost, meaning that when you look at their contract, what they're putting at risk in that with that 6.6 million is 1.2 million. So that's included and embedded in their actual base cost. different than what some of the proposals are, and that's why we tried to equalize it. So if we normalize that by saying that what are the actual specialty costs and what are going to be a part of that, then that gets it to the $5.4 million level. What we were asked to do is look at a base population of 1,550. Currently you're in the neighborhood of 1,510, and the exercise was, let's try and equalize it to see what happens at 1,510. That's the additional $80,000 in the current contract. The assumed specialty cost, we assume for everyone would be the same. That assumed specialty cost is that $2.34 million, and that's approximately what it is today, looking at some of the averages. Some of the information you got has the total numbers at somewhere in the neighborhood of $7.6, $7.7 million. So looking at this factor, it's going to be a little higher because of the $1,550. Now that specialty cost is the area of fluctuation. And you heard some of the comments on how the savings would be generated by some of the different companies that came up. So when we looked at the actual proposals themselves, that's the starting point. That's how it's done. That's how it's done today. Then looking at the proposals, Armor has their proposal based on 1,425 inmates. Their base rate is $339.65. There's nothing included in our base rate on the specialty costs. Now they did say that their specialty costs would be $1.215 million that they talked about earlier in their presentation. The actual base of that $5.8 million we did not adjust because it's not included in the base itself. Their actual charges for the population that would be above, in their case, 1,475, would be about $65,000 in addition to their actual base cost itself. We assumed the $3.24 million, and the question that could come up on that is we did it for everyone, because we said that your cost would be the same no matter what it would be. And then you would have to have some discussions with the different groups as to how you would see them saving on that $2.34 million with some of the things they bring in-house or some of the management functions that they would devote to that. To look at Armor specifically said that 1.215 million would be a part of their actual specialty cost. So that would be part of that $2.34 million that you see here in the assumed specialty cost.
Okay. Okay.
Now,
Okay, I get it. I'd like to hear from the vendors here. Could I have Armor address this, the specialty costs, and then Kreis and CCS speak very briefly on all three on this? Do you understand my question?
Yes, ma'am.
Okay.
Bruce Till with Armor, CEO.
CEO of?
Armor, I beg your pardon, of Armor. A couple of things I'd like to point out. First of all, the adjustment for the population, 64,879. Typically, in every contract that we have, there's a variance of, and I'm sure probably our competitors as well, there's a variance of about 100 to 150. And what that simply means is if the population goes above 1425 or below that, we would not bill for that. So from the analysis perspective, frankly, that I think probably for all vendors that would be removed. The second component is, that's what I alluded to earlier in our presentation, is literally the $1 million question. That now makes more sense based upon the article that I read. We did not anticipate, in regard to these specialty services, to be running anywhere near the $2,340,000. I tried to cite numerous examples in regards to, as compared to predecessors, our first year's performance. So when I sit there, and it makes a little bit more sense, you have a base contract, and that's where it comes in regards to the surprise at the end of the year. You have a contract, but then all of a sudden it's running, I think you said $7.6 million. That's why I was alluding to all the rebates that we've actually given back. So one of the things that we do pride ourselves in is on the on-site specialty services, just as everybody's alluded to. I mean, some of our contracts, we bring up to 13 different types of specialists on site. So I don't know if that answers your question or not.
It does.
And just, if I could clarify a piece of that too, the inmates over are based on your proposal of any 75 inmates above the 1,475, because there was the 50 inmate fluctuation positively and negatively.
The 50, big front.
50 either way. Yes.
I'm not getting tied up in those kind of numbers. That's why I want to hear from them. I'm looking more across philosophically on why you chose not to bid on specialty cost sharing. That's really what I'm looking at, not specifically the numbers.
I believe it's really in the presentation of the pricing schedule that we received. I think that it sounds like one vendor, I guess CCS interpreted it the same way we did, is not put it on the base specialty, but isolate it separately. It's certainly part of our proposal, the specialty services. So, I mean, the base services, which includes all services with the exception of all sites. So base services is all personnel costs, all specialists and things of that nature. So.
Ryan Ahern, Director of Financial Operations. It was, in the answers to questions, it was, yes.
Please state the company name.
Sorry. It was directed to actually present it that way. So we asked a question stating that, and we were directed to separate the two out on the price sheet.
Tina Rose, Director of Client Partnerships for Correct Care Solutions, and we have the same information. So, yeah, on our pricing form, what we have is a $1 million amount that was separated out for that amount that I referenced in the proposal, the qualifying aggregate costs. There's a $1 million pool for those costs. And printed out really small, but that includes hospitalization, referrals, consults, HIV and AIDS medications, dialysis meds, and those non-formulary psychotropic medications that I had referenced prior.
Okay, so you did identify the specialty cost sharing.
Absolutely.
In there, it's just not identified, okay. And Horizons, we know is there, thank you. Thank you. We're talking about litigation, and this is on one of the questions this was given. We have inmate medical RFP questions of point of consideration looking at this. Horizon, it's known that there's quite a bit of litigation that you're involved with currently. I mean, it's current, and I have to tell you, while I was sitting here, I just Googled the companies and Moody's ratings, because you are a for-profit corporation, because it's not just you that's here in Volusia that you'll be representing. You're impacted not just statewide but nationwide on how you conduct business. And as I was looking at this, I'm looking at this with Horizon, that you have over 660 malpractice suits, and only half are settled, and that Moody has downgraded your debt to B2 negative. Is that a true statement currently? I mean, and this article is 2014. Well, this one is October 10, 2013. The other was 2014. So.
And what is that article source? Is that
turnover at the top, financial downgrade?
The website is.
There's several. It's the same article. It's the same. This is quoted from the Sun Sentinel, Florida Corrections Department. My question to you is, your parent company is Volitis, am I saying that right? Horizon Volitis? Is that a true statement?
Yeah.
Okay. So I guess my question is, from a business perspective, is risk. And because it is a for-profit situation, and profit is the bottom line, is this going to compromise the services rendered from a business standpoint? That's what I'm looking at. That's my concern.
Martha Harbin, Horizon Health, Director of Business Development. The short answer to that is no. Horizon is, it's in a strong financial position. We went through a corporate merger and a buyout, and I don't want to say wrong to the Moody's number, but I knew we took a hit on Moody's, but I know that in the past year, and again, I'm hesitant to throw out a number because I know I'm on the record and I don't want it to be wrong, but we paid back like $35 to $38 million of our debt in just the past year alone. So there was some restructuring, and Moody's had a, opinion on that. They were the same ones that said Goldman Sachs was AAA, but anyways, and we've been able to, turn that around and pay back $38, million of debt in this last year, and, things are moving forward positively. I just joined the company in April, and I felt like I was taking a good risk by coming on board. Our future is bright. To the litigation.
Did you just say that you were taking a risk by coming on board?
No, I did not feel I was taking a risk.
Thank you.
No.
Thank you for
No.
clarifying that.
No. I would not have changed ships at my age if I thought it was, I thought I was putting myself in a bad situation. Did we want to talk about litigation? I mean, you brought that up, but then we moved over.
Well, yeah, I mean, it's on the record in several places. But I want to back up a little to pharmacy. You have an in-house pharmacy corporation?
Yes, ma'am. PharmaCore is our in-house pharmacy provider. That was a point I wanted to make in my remarks, and I think I failed to make it. An area of cost containment, I think, that we offer to the county, and we weren't in a position to put it in our proposal back in April because of some contractual relationships that we had at the time. But those contracts are now expiring, and as opposed to working with an outside pharmaceutical provider who would have administrative overhead costs, we have the capability to shift to our in-house PharmaCore, where you would not be charged for profiling and some things like that, and we think we can save the county some money in that area. It wouldn't be money over the base rate, it's some money on those off-site, those out-of-pocket expenses that you pay. We also will be able to take advantage of SMA's second trip pricing, and then the work that we did to get the county in a posture to participate in the 340B pricing again will offer some savings.
Okay. And just, I heard something in presentation, I don't know who said it, but ARMA may have said it during their presentation, that Volusia County, we don't have a fully functional electronic health record system. Is that true? Okay. So should a change occur, a transition, we are in a transition currently with our electronic health record system. Is that a true statement?
What we've done as part of this RFP, we've requested whomever comes in, that they bring in an electronic system, because we have a paper system. So we figure this was our opportunity to upgrade our system with whomever comes in.
Okay, thank you. That's just some technical questions. And as far as Councilwoman Cusack asked a lot of the questions that I want to know too about doing on-site delivery of services, medical services. That was good. So thank you. Mr. Chair, I'll pass right now. My colleagues ask questions.
Okay.
I reserve the right to come back later, but thank you.
Yes. I'm the only one on the list. Okay, well, here's what I would like. I would like the three executive officers to stand, come forward. I'm going to ask all three the same question. So whoever's in charge of your administration, and I'm just going to start right off with Arrow. How many employees on site will you be employing here? You'll have to go to the mic. Arrow. Or I'm sorry, Armor. A-M-O. There's Oregon.
Armor. Okay, Bruce Teal, CEO of Armor. We have reflected in our staffing matrix 47 total employees on site, and anticipation that if we were to be selected, that the vast majority that would want to stay would remain with us that it's currently serving there. And as Mr. Gehring illuminated or illustrated earlier, there might be where when we get in there and you really know the system, it might take a couple more. If it does, that's as we illustrated, that's on us. But 47 to answer your question.
At this point, 47.
47.
Okay, CCS, how many people do you, it's one question with 27 parts to it, so don't sit down. CCS, how many?
Yes, sir. Bill Kissel, Regional Vice President, Correct Care Solutions, 48, sir.
48. And Horizon, we have,
Jane Lackner, Vice President of Operations, 50.6.
how do we get 0.6 people? I'm just going to round it up to 51. Okay, with that, all right.
Some of us are really short.
All right, let's start off with Horizon and go back the other way. Employee turnaround, how many times do we have to replace a staff member there? For whatever reason, they left, they moved on, were promoted.
Promoted, yes. We've had some turnaround. We really have, at the facility, we have a very stable staff right now. We're looking for some PRN people. We've actually increased rates over the year again. It's competitive here. I mean, Halifax and then Florida Hospital. So we know where we have to be in terms of our rates. Our orientation is excellent. Our people are feeling comfortable. So, but we've had our share.
Okay, so 40%, around percentage.
65% have been there longer than 2 years.
55% have been there. 55% of them have been there over two years.
That-
45% over 4 years.
45%. We'll limit it to 2 years, Mike. Okay. Okay, so we're going to say 45%. CCS, pick a comparable site. huh?
Bill Kissel, Regional Vice President, Correct Care Solutions. A comparable site would be Pasco County, Florida. Our attrition is less than 30%. We have been 100% staffed since day one.
Okay. And Armor, comparable site, but I'm going to hold you to that site.
Bruce Teal, CEO Armor. I would say roughly 25% with the 15 accounts. It will vary, obviously, in the first year, second year in operation versus 10. We have mature sites that have none, but I think a good benchmark is 25%.
Okay. And let's see, I think we have a cost per unit here. Okay, so I don't need to ask that question. You've already answered, and let me just clarify. Armor, you periodically use agencies for nursing staff, and CCS said no, and Horizon said no.
Yes, sir.
Am I correct in that statement?
You were correct in one statement. Very rarely.
Very rarely. Yes, very rarely. I will stick to that. Local nursing schools. See, I'm sure everybody is an amazing medical facility. You guys take care of your patients and all that. I'm more about the money and jobs. And our local nursing schools here, would you be willing to work with our local nursing schools to bring them in? We'll start with CCS this time. We'll kind of rotate you around a little bit.
Bill Kissel, Vice President of Operations, Correct Care Solutions. Yes, sir, we embrace the opportunity to partner and have interns in correctional future healthcare professionals rotate through our facilities. We think it's a great opportunity for recruitment. It's a great opportunity to keep people close to where they went to school. So yes, sir, that would be a great opportunity. We would embrace it.
Horizon? I'm just going right through the list here.
Jane Lackner.
Do we currently work with Daytona State College, Embry-Riddle?
And UCF, and yes, we do, and Alicia goes there constantly and talks and gives speeches and does job fairs.
And I'm going to go out on a limb and say yes, but go ahead, Oliver.
Yes, well, actually, we included an intern in regards to the mental health program here, if memory serves. So it's not just nursing. Of course, we embrace that. Also, we've had, and we demonstrate like Nova University, so it's not just going to be nursing, it's going to be mid-level positions, both in the medical and the mental health. But absolutely, that's the best recruiting tool. Yes, sir.
Okay. Okay, everybody's already gone over the lawsuit thing and beat that to death, so I'm not going to ask that question. Does anybody have a pending lawsuit on them at this time? We've talked about the past, I'm talking about the current. Is there anything that's pending that may be worth raising an eyebrow or not?
Martha Harden, Director of Business Development for Horizon Health. you have the benefit here because we're the incumbent, so you know, the history of the site, the history with these people.
Well, believe it or not, I do not.
Oh, okay. Well, excuse me, because I read the paper this morning and got alerted to the fact that some of these questions might come up, so I made sure that I had the most current numbers. Since
Somebody was reading my mind.
Since taking over the site from Halifax in 2005, we've had 10 lawsuits in Volusia County. Of those 10 cases, 5 were dismissed for lack of merit. As you probably know, inmates are one of the most litigious sectors of society. A lot of times pro se, a lot of times they. So you can get sued 600 times easily. It doesn't mean they ever go past page 1. Okay. Especially when you're the oldest company out there, and most of the chief executives of the other ones started out at your company and went off to start other firms. But okay, so let's see.
So you have 5 pending.
5 of those were dismissed for lack of merit. 2 cases were settled, and 3 remain open.
Okay, we have 3 remaining cases. I won't go into numbers or anything because there's process. We're going to go down here to the next one is Armor. You're next up. We're going to stick with, let's see, you picked one of your facilities.
Well,
A comparable facility. Which one?
I can tell you that right now, company-wide, it'd be tough because we look at things and this is.
Pick one.
This one. We don't have any amenities.
Nothing pending at all?
Nothing pending.
In Florida?
Well, with a like-size contract, not like, I'm just using Manatee as an example.
Yeah, okay. Don't break that. I will charge you for that.
Ted Plummer with Armor COO. I don't want to misrepresent. I don't want you to think of a similar size site as Manatee where we currently have none.
Okay.
We do have other sites that are similar size in Florida where there might be 1, there might be 2.
Okay. See, I don't want to pick on Corizon because Corizon's saying, well, here we have, and I don't want to misrepresent that.
We don't have any.
Right.
That's not what we're saying.
And CCS, you quoted Pasco County. I'm going to hold you to Pasco County. Do you have any pending lawsuits down there?
No, we do not.
No, sir.
Okay. There was a question, I got 2 more questions, and then Ms. Northey, and then Mr. Daniels. My 2 questions, one more question is that I'm sure we have a good relationship with Halifax over here at Corizon. Do the other 2, let's see, we'll start with Armor this time. Do you have a working relationship with any of our local hospitals that may save us money in the long term?
Well, we do not have a current relationship with Halifax. We've obviously reached out to them as part of this process.
Of course.
And as is customary, they like to see what the outcome of this is before they get specific as far as negotiations. I can tell you, we have multiple hospitals throughout the state. They're actually references for us. So, I mean, we would be, from day one, would immediately, we have an idea, we know their rate structures, we know how their Medicaid component works, we know what the percentage charges, that type of thing. To go to your question specifically, we do not have a contract with Halifax Hospital right at this moment.
Okay, CCS?
Bill Kissel, Regional Vice President, Correct Care Solutions. We have been and will be in active discussions with Halifax, with discussions focused on discounted rates, which will in turn be a benefit to the county.
Okay, and there was one other statement Corizon made was that you had an in-house pharmacy. Basically, you have pharmaceuticals brought in and through your corporation.
Yes.
Yeah, through the parent corporations.
Okay, like the VPO, yes.
Okay. Let's start with, we hit Armor first, let's go with CCS. Do you have a similar situation?
What was the question again, sir?
The question is about an in-house pharmacy. Do you have a parent corporation or a partnership with a pharmacy that brings in all your pharmaceuticals to take care of your patients?
Yes, we have a relationship with a number of correctional-based pharmacies. Maxor, I believe, is our partner for this initiative, but we do not operate our own pharmacy.
And Armor?
Bruce Teal with Pharmacia, we do not, it's a philosophical difference, we don't want to operate our own pharmacy. We as well have Maxwell as we utilize as well as another one, Diamond. We'd like to have multiple pharmacies. One, it keeps, I don't know if we're honest, but keeps them competitive service-wise, price-wise, so we would also anticipate using Maxwell here.
Right, that's all the questions I had. Thank you very much. I guess you can have a seat. Ms. Northey, you have the floor.
Okay, you covered a lot of ground, Mr. Chairman, so let me just ask, I believe I heard somebody say that can we talk about the proposed staffing matrix again? Because Armor lists on their, in the book, that the current is 47, and I think Horizon said it was 50.6. So I'm going to ask our staff, what is the current staffing now?
47.
47. Okay, so why would Horizon say 50.6?
Ma'am, this is Jane Lackner, Horizon DPO. I must have misunderstood the question because I thought they were asking what the proposed staffing would be, and we are proposing 50.6.
You're proposing, okay. So back to Armor, your changes on your staffing, you're reducing a registered nurse position for psych and a licensed practical nurse for psych, and it looks like you are making them all LPNs. Is that correct? And why, if psych is such a big issue, why would we be reducing specialty?
Angela Gehring, Senior Vice President, Clinical Operations with Armor. In the state of Florida, to hold yourself as an RN, a psych RN, it's a special certification. And it's been our experience that very, very few RNs truly are, quote, psych RNs. There is not such a thing as a certified psychiatric LPN in the state of Florida. We train all of our LPNs and our RNs to recognize symptoms of mental health illness, and we don't segregate mental health from physical medicine. So you would get the same service, we just call it differently to stay
Okay,
within
well, tell me where
practice.
you would have gotten the mental health professional, or no, excuse me, registered nurse psych and licensed practical nurse psych, when you say the current one, the current contract has one of each, and you're saying that that's not accurate to the current contract. Where did you get those ones from?
We are suggesting that ma'am, that we don't have a registered psych registered nurse, that we would.
You're suggesting that we don't have that now, is what I think I heard you say, because you just said there's no such thing.
The answer to questions, if we got an itemization of all the existing positions as defined.
All right, so let me go back to the staff then. Do we have the position listed as licensed practical nurse and registered nurse psych?
Yes, we do.
And do we believe that there is in fact a specialty for psych, for nursing?
That's my understanding, yeah.
Okay, and you are Armor,
Yes.
and you're saying that's not so?
You can be a psychiatric registered nurse. It's a master's level, so they may well have that. I can't speak for them. We actually suggested that we don't have a psychiatric RN. We added a .6 psychiatric ARNP, which is an advanced level nurse who's able to diagnose and prescribe medication for those patients, which is a much higher skill set than a psych registered nurse would be.
Okay, so let me go to all three firms and talk to me about your healthcare, and I heard bits and pieces of it, but you are currently, Horizon is contracted with who for inpatient services? Who wants to speak to that? You know, y'all are in the same kinds of suits. It's really hard.
Well, we got to address this one. I said we only needed little Horizon patches now. We're for inpatient services with Halifax Hospital. They've been negotiating back and forth with Florida, Florida Hospital. Florida Hospital. That's where we had our business.
Okay, and Mr. Eckert, we talked about this when I was in the meeting, whether those numbers are public record. And you said you believed that once those numbers were, once that contract was signed, that would be a public record. Is that correct?
Yes.
Okay, thank you. All right, what about Armor? Who are you all? Do you all have a contract? I would assume it would be contingent upon receiving this one, but who are you talking to?
Well, we have a contract with Florida Hospital currently, and as I alluded to earlier, Bruce Till with Armor, CEO. And we are in talks with Halifax Hospital, as they alluded. If we would be the vendor of choice, we would sit down with them. Frankly, we want to sit down with corrections so they can understand that any type of discounts that are received go back to the county. So we're reaching out to them as late as yesterday.
Okay. And
Bill Kissel, Regional Vice President, Correct Care Solutions. We are currently, ma'am, and have been in negotiations with Halifax if we're fortunate enough to be awarded this contract. And we will be working to secure favorable rates. And additionally, we've also recently partnered with Cigna, and we will then have access to their network of providers in an effort to reduce costs.
okay. So let me talk to you about your billing practices. You all, a patient, well, prisoner comes in and he requires inpatient care or he requires outpatient, it doesn't really matter. If he has insurance, you all bill that and recover those costs?
Like your VPO Horizon. Yes, currently, in all of our sites, we do that. We ask an intake if they have insurance. We also ask during the history and physical, and before they even go out, if they, again, do you have any insurance? We also have suggested Inmate, which will also bring up their current insurance, which will be very helpful because there's a huge portion of people that are now insured through the ACA because they're right. And we're capturing more and more of that. And then behind the scenes, we contract with other companies whose job it is to get into, through computer programs, and they actually have people running around, they look through medical records, and they really look hard to find any other, say, car insurance, whatever it is, they look for it. And we've recovered $120,000 for the county since 2008.
Okay.
But yes, they bill insurance companies. That's what we do. We have the hospital building insurance companies, actually.
Okay.
Gina Rose with Correct Care Solutions, Director of Client Partnerships. We do look for those opportunities, yes ma'am, to bill those third-party billers where that's appropriate, and we actually track that within our care management system. So when that patient comes in, we're able to go ahead and track that the county is not financially liable for those dollars. And when a claim comes in, that communicates to our claim system. So if for some reason that claim comes into our agency, we're able to go ahead and reroute it to the appropriate agency. That has allowed us, and similar size facility out in Kansas and Johnson County, we've saved them numerous dollars there through avenues like that as well throughout the country. So.
Okay.
Ken Pullum, the COO with Armor. We don't pay any off-site claims until all available resources are exhausted. And we track all that. Now, I don't want you to be mistaken with the PPACA, or Affordable Care Act. In Florida, it's very limited as far as the effect it's going to have on you right now. As the largest provider in the state, we monitor that. We have a letter from the government saying right now, as far as Medicaid, it's not an option, so there's no benefit there. Most insurances, private insurance, once a person's incarcerated, there's no longer benefits, but to the extent there are benefits, we maximize those.
Medicare, you bill Medicare.
Excuse me?
Medicare?
You can't bill Medicare.
You can't bill Medicare. Is that federal?
That depends on, if the site is set up, and it's strict, but if the site, that's a site-by-site Medicare. If the site is set up specifically so that it meets the Medicare responsibilities, there are possibilities there. But as far as Medicaid right now in Florida.
I know Medicaid is okay. So I'm going to go back to the staff and ask this question. Someone comes in, they're required to go to the hospital, and a provider, how do we know from our side that, I'm assuming that we get a bill from, do we get the bill from Halifax, or does it go through the provider?
It goes through the provider. It goes through the provider.
And then how, is that part of the existing contract, or is there an additional cost to us that comes back to us? I mean, what if it's a catastrophic patient?
If they collect on the insurance,
No, I'm saying, let's just say there's a patient goes into Halifax, it's catastrophic, it's a $100,000 bill. What happens to that bill and our contract with the healthcare provider?
Okay.
Is there like a level that says this amount is included in the contract, and above that is catastrophic, and county, you're going to pay that? I mean,
okay, Marilyn Chandler, Ford Corrections Director. If anybody goes to the hospital, whether it's an emergency room visit or they stay, that is included under specialty care. That bill goes from the hospital to the contract provider, Corizon. They have their staff work on a negotiated discount. Some of the discounts they already have in place, other ones they continue to try and, chip away at amounts. For example, we had somebody in within the past year that the bill would have been $1 million, close to $1 million, and Corizon, once they had worked with the hospital, got it down to about $250,000, so that we paid 25% of the original billing. That goes into Corizon. Corizon then turns around once they've finished all their negotiations and billing, and then we get notified of what that amount is we pay. And so in many ways, we don't see that cost for 2, 3, 4 months. But that's part of the specialty costs. Monthly, we get a notice of what the specialty costs are, but those may have been from several months prior. And then if Corizon gets any collections from insurance, my understanding, that's a deduct off the bill that we then see. So we will, at the end of the day, the jail sees the final bill or the final product.
okay, all right, thank you. And so, Mr. Eckert, to you, we touched on this conversation as well. We have 3 indigent care hospital care districts. Why do we not bill them? Or why do we not ask Corizon or Armor or whoever gets a contract to bill the hospital districts for indigent care? And we can determine that these inmates are indigent.
Well, this is a topic we can, here's the short answer. The general law says that the patient is responsible for the bill, and that ultimately the county general fund is responsible if there's not, if the patient does not have the resources or if there's not insurance.
When you say patient, are you referring specifically to a prison, a jail patient?
To the
just general?
inmate or detainee.
Okay.
That's
state law?
Yes, ma'am. In chapter 901.
You don't need to. Don't cite the chapter.
What I'm saying is, when I say that,
I'll take your word for it. Seriously.
It's general law, and the hospitals, that statute says that we pay the provider. The provider may bill, and it is to bill, and ultimately we stand after the assaultant, inmate or detainee, or insurance coverage. The hospital districts are authorized, but at least in my understanding of their special act, and we've taken a look at it, they are authorized but not required to provide indigent care. Their responsibility to, as I would understand the law, to provide for indigents, the requirement to provide for indigents rises largely under federal law. So what you have is a general obligation, general law obligation, and they're discounting their rates but they're not required to provide that care. And of course, the part that your question includes the premise that for the care provided in the hospital, they don't have the responsibility in our facility.
Well, it sounds like the law and legislation has not kept up with current healthcare market. I mean, it just hasn't.
This is a 1983
Right.
enactment of the legislature. In effect, it's a
So 30-some years later, and healthcare has changed incredibly so in 30 years.
well, it's really, so far as the legislature is concerned, it's the mechanism, it's an unfunded mandate, but it's a constitutional unfunded mandate because it's preserved because of a law that was in effect prior to 1989. It's the legislature saying which public pocket is responsible. And we might work with the hospitals, we might even try to litigate it. I think they're going to take the position that they're authorized but not required to provide the indigent care. And we do have a specific statute that says that the provider, the predicate for it says that the individual is responsible, but the provider can ultimately is entitled to bill the general fund.
Okay, but hospitals are required, if it comes into the emergency room, and I would assume these would be emergency rooms, they're required to take emergency patients. So all right.
But they,
So
the person that arrives by their own means is not accompanied by a statute which says that the county general fund has to pay.
Right. Just one other quick question, and then I'll be done. I'm done with that end of the discussion. It's just ridiculous. Oh, no, one other thing. In our lien that we're going to be bringing back, we have not added ourselves as one who can lien. If there, for some reason, was car accident, they were found to be, and as a result of that car accident, there was an arrest warrant, and they went to jail, yada, yada, yada. We had that conversation as well.
Well, I've had the opportunity to look at the statute since we spoke, and the statute does provide the opportunity for us to, for a lien where the result, where the injuries are the consequence of an act of liability of a third party.
Okay, finally, and if you said this, I missed it because we've said a lot of stuff today. What programs for reentry? Do y'all do any kind of a program for reentry into the community? Go ahead. You can go first.
Bill Kissel, Regional Vice President, Correct Care Solutions. We believe reentry starts at admission. So in a jail-based setting, we will start providing education for services and providing information for services at admission, because that you never know when that person is going to leave. I mean, he may or she may be being bonded out in 10 minutes. So you want to make sure whatever opportunities that person may need, you address as quick as possible. For those people that stay longer, we work hard to connect with the behavioral health community, or if there's a chronic illness, with the public health community, to ensure there's continuity of care. The model you have developed here is excellent for that. We do groups that are reentry groups to help prepare with life skills, simple things like how to prepare for a job interview, how to navigate transportation, those kind of life skills things. And we also work with other agencies to assist with wraparound services such as housing, healthcare, transportation, and whatever. Yes, ma'am.
Okay. Next up.
Maria Brooks with Armor. Just as was mentioned before, reentry does begin at booking. We work very close within all the communities, so the partnership with SMA wouldn't be new to us as well. In one county, we've actually had Program of the Year, where we did the implementation of discharge services, and in addition, one of the facilities where we're Facility of the Year, they had highlighted on the discharge programs, which again begins at intake, not only with mental health, but medical needs as well with the HIV population. Something that we're moving more towards in a lot of our newer contracts is diversion programs. So even when they come in the front door, looking for some diversion, so they don't even spend long periods of time in the jail.
Correct, I think it's, what, then I will be done.
Wasn't gonna let all this stuff, but I wanted to hold up a picture if you didn't have it. We take reentry very, very seriously. We understand the link between recidivism and reentry, and a successful reentry can make a big difference in whether you see that person again. Through our partnership with SMA, there is a reentry coordinator who works with the planning and the discharge, and we work with the Haven and Project Warm to help folks, get handed off and be taken care of and continue their meds and that sort of thing. We also have started our Horizon reentry portal that is in our proposal. This is just a page out of our proposal. It is
Could you hand that to one of your staff members and have it, give it to Ms. Marcy?
Oh, sure.
That way she can put it on the overhead.
Oh, great. It's an internet portal that's for both inmates and their families. It's one-stop shopping for community and state and federal, resources, not just healthcare, but faith-based organizations, housing organizations, food organizations, kind of one stop where they can go in and get resources. So we take that very seriously, and as part of getting this portal ramped up and more vibrant and putting as much information as we can get in there is, real focus right now to get that going.
Okay, thank you. Mr. Davis, I am done.
And I see no further comments or questions. Ms. Jennings, it's your turn now. Please explain to us how we're going to do this. By the way, thank you everybody for your presentations. Very informative and some good answers for some of these questions. Ms. Jennings, you have the floor.
Thank you. Janine Jennings, Director of Purchasing and Contract. You're getting a ballot right now. I ask that you put a number 1 on your selected vendor and sign your ballot. Everybody's name is on there. If you will just put a number 1 under the vendor that you choose. It will take 4 number 1 votes to award a contract. If we have a tie, we will do a second vote. Just one. Just a number 1 on the one you choose and sign it. Anywhere.
It's Florida sunshine. There will be after it's ready.
Okay, Ms. Jennings, how long do you think that will take? Should we take a short recess for you to return?
I just want to make sure I have everything and that I double check everything.
Okay, so this should take no time at all.
It's pretty cool,
Mr. Chair,
Yes, yes.
while we are waiting,
Identify yourself, please, ma'am.
Mary Ann Connors, Deputy County Manager. I would like to thank the county staff for the work that has gone into providing a background and a context for your consideration today. Thank you to Dr. Ford and her staff, Mark Flowers, Greg, thank you so much. Thank you to our consultant, Mr. Robinson, who brought a level of expertise to our advantage. And thank you to George for holding all of this together and helping to marshal this through. I appreciate all of their efforts, and I hope it informed your decision well.
Yes, thank you very much. It was almost like getting an Academy Award. That's how they do that. I'd like to thank my mother, my brother, George.
This is a tough crowd here when you have somebody who's a former hospital administrator, a registered nurse, 2 people who sit on the board of directors of the hospital and quality board, 2 licensed health insurance agents,
And a couple of
personal injury
attorneys.
attorney.
It didn't say
And a radio guy.
We were listening.
Yeah, and that's kind of funny. The attorneys said nothing.
You guys asked enough questions.
Wait a minute. Yes, order. Ms. Jennings.
Janine Jennings, Director of Purchasing and Contracts. I am going to read the votes at this time. County Chair Jason Davis selected Correct Care Solutions. Joyce Cusack, Armor Correctional Health Services. Pat Patterson, Armor Correctional Health Services. Josh Wagner, Correct Care Solutions. Ms. Denny's, Armor Correctional Health Services. Mr. Daniels, Armor Correctional Health Services. And Ms. Northey, Armor Correctional Health Services. We have a overall selection of Armor Correctional Health Services. At this time, I'm going to ask for a motion.
I will entertain a motion. Oh, easy. I got a motion for approval from Ms. Dennis to my left. I'll take a second from Mr. Patterson. Any further discussion? Seeing none, all those in favor signify by aye. Aye. All those opposed? So carried.
Thank you.
Thank you. Congratulations, Arma. And we will be in recess. We are going to take a 1-hour lunch break back here at 2:30 p.m.